All right, we'll go ahead and get started. Once again, for those of you just joining us, my name is Leanne Foster, and I am a Provider Outreach and Education Specialist here at WPS, and I want to thank you all for joining us today. Our session today is going to be talking about E&M services with Modifier 25 and other Part B services on the same day. That's a mouthful. So today, as I mentioned earlier, this is going to be two parts. The first part is going to be focused on the basics of Modifier 25 and billing practices, some tips for you. And then the second half, Mary Sue Gardner is going to be providing some live demos of documentation to help with that. That tends to definitely be the piece that people struggle with the most. So in order to do that, what we are going to do, our objective is to provide you with a better understanding of when it's appropriate to report a separate E&M service with another Part B service using that Modifier 25. So in order to do that, as I said, we're going to be talking about how to use that Modifier 25 when billing. It all comes down to what was done for the patient and if that documentation is going to support that. So we're going to talk through what we're looking for and give you some examples. We are going to also show you both sides of it, including the appropriate and inappropriate uses of Modifier 25. And then, as I said, the second half of this, I'm going to be handing the session off to Mary Sue for some documentation examples. That is really, you're going to hear us talk about documentation and that the documentation must support a lot today because it really does come down to that. A couple of things of note, acronyms today. I do not have an acronym slide included in this session. However, acronyms are in the notes section of the training material today. So you do have those acronyms where they're being used if you need those. And also we do have a few disclaimers at the end of the presentation. Those disclaimers include some disclaimers from the American Medical Association and the American Hospital Association because we will be providing you with some CPT code information. Just calls out that we don't control that information, but those are there if you'd like to take a closer look at those. I want to start with some basics regarding E&M services in general, just to set a baseline. So typically, an E&M service, that is going to be a per diem service. This means that Medicare typically pays for one E&M service per day when it's performed by the same provider. Same provider is defined by MPI, so same person, by the same group. This is going to be defined by that tax ID. So if you have multiple providers that are part of that same group and they're of that same specialty, Medicare considers them to be that same provider. So same specialty comes into play. That same specialty is going to be the 2-digit specialty code that the providers select during enrollment. We'll often get questions about taxonomy code, but in our claims processing system, it is set up to utilize that 2-digit specialty code. So just keep that in mind that we're not looking at those taxonomy codes, particularly for this definition. Multiple E&M services in one day are going to have some situations where they are payable. They could be payable if they were provided in different settings. They could be payable if they're provided by different providers, again, meaning different group or different specialty. We did get a lot of questions that were kind of we're lining up with this about providers in a different clinic, things of that nature. Those are going when we're talking about that Modifier 25, we're talking about services provided by the same provider on the same day. So keep that in mind. Services are also going to be payable if they're unrelated and they could not have happened at the same time as that service. So an example, patient comes in for management of diabetes in the morning. In the afternoon, that patient comes in because they've fallen and they've injured their elbow. So these are going to be unrelated and they couldn't have happened at the same time because the patient hadn't fallen and hurt their elbow when they came in for the management of their diabetes. That would be an example of where you could bill multiple E&M services. But as we're going to talk through this, you're going to need to apply the appropriate modifier, and that's going to be Modifier 25. Now, sorry, that got stuck. Okay. So the question that we get is when a patient has a procedure, we get this very often, but when a patient gets a procedure, it's important to remember, providers are wanting to bill for that separate E&M. It's going to be the focal point of a lot of what we talk about today. It's important to remember that when a patient has a procedure, there are elements of E&M included as part of that procedure. So because these E&M elements are part of that procedure itself, typically an E&M service is not separately payable. However, there are going to be exceptions. And we're going to spend a lot of time, spend some time on those exceptions today and providing some examples. And also, again, we'll be showing you some documentation examples later on. But the exceptions are when the E&M services can stand on their own as a distinct service, or they are a significant amount of work above and beyond what is considered typical for that procedure that's being performed. We are going to go into the definitions of separately identifiable and significant, but I do want to call out again, in order to bill for the separate E&M service, you are going to make sure that you're using the appropriate modifiers. So we're going to start with that modifier 25, what it means and how it should be used when billing Medicare. So the definition of modifier 25 is that the service is significant and separately identifiable. So as a reminder, modifiers provide a method of communicating circumstances that will alter or modify the service that's being billed as it's defined. While they're not going to change the description of the service that's being billed, they do allow you to tell us some additional information about what occurred to help tell your story of the service provided. Everything's not cut and dry as far as it's always going to be this definition. So these modifiers really help you tell us some additional information. Modifiers can be both informational or they can allow for additional payment. That allotment for additional payment is the case for modifier 25. So it is super important that they're used properly, because if those modifiers are used properly, they can result in rejections and denial of claims. They can even result in overpayments. All of this is something that we want to avoid for you, the provider community, but we also want to avoid that for the Medicare Trust Fund. So the definition of modifier 25, that tells us that the service, as I said, was billed as a significant or separately identifiable evaluation and management service that was performed by that same provider or other qualifying healthcare professional on the same day of the procedure or the other service. So breaking that down, to use modifier 25, the E&M has to be significant, so above and beyond what's typical. It has to be separately identifiable. It has to be performed on the same day. If you have a procedure that was performed yesterday and today you're doing an E&M, it is likely that those can be billed. It's a little less for the procedures, a little bit more for the other services. But if you have services that are performed on different days, they're performed on different days. We're looking on that same day. Also, same physician. If you have services that are provided by different physicians, they are going to be payable and not need that 25. I have included a link to the modifier 25 fact sheet. It gives a few more examples so that you have that for reference, and that's in the training material for today. But I want to talk about a little more about what that significant and separately identifiable piece means. We did receive quite a few questions that relate to this. So I want to start with significant. So significant means that the E&M service was beyond the usual care typically associated with the procedure. It's telling us that it wasn't an integral part of that particular procedure, but it can include services that were preoperative, intraoperative, or postoperative. So when it's with a procedure, you have to think about that. But it has to be what is over and above and beyond what is typical for that procedure, and the documentation has to support that. Separately identifiable is that the E&M is a separately identifiable and distinct service from the procedure or the other service that was performed. And again, that documentation has to support. Some questions to ask yourself when you're looking at this separately identifiable piece. Does the patient's condition require a separate E&M service, or are the services that you're providing really part of the other service or procedure? Are they integral parts of that? Also, you want to ask yourself, is this separate E&M service medically necessary? The determinant for coverage for anything Medicare is the medical necessity piece. So you want to make sure that that documentation is supporting that it's medically necessary. You also want to ask yourself, was this a great amount of additional work? Again, if it's a part of what's typical for that procedure, you can't count it for a separate E&M. So you want to make sure that you're looking at that. The E&M service needs to demonstrate that there was significant medical decision-making beyond what's normal for that procedure. And one thing that we'll often say is looking at that procedure, that other service, pull out all of your documentation that supports that service and look to see what's left. Because you're not counting the MDM or the documentation twice. So pull out what is specific to that procedure, and do you have enough to support a separate E&M service on that day? You're going to hear that a lot from me today. So I do want to give you some examples here, though, of when it could apply. So one is for significant. There we go. So for significant, what we have here is that for our first example, we're talking about significant, and you have a patient that came in today for eye injections. So during that visit, the patient is telling the provider that they've noticed some changes since their last visit. They don't know which eye. They don't really know what is changing. They just know that their vision has changed, and they're concerned about it. So the provider then performs an exam to determine, and then in that exam, they determine that they need to order additional tests and interpret those. So when you're determining that significant level of effort, you have to think about if the services provided during the procedure are that integral part of the procedure. If they are, they are not billable as a separate E&M service. If the services are significantly above and beyond what's typical, and in this example they would be because they have a new complaint, they're having to do more testing. It's not as simple as that eye injection that day. That is something, as long as the documentation is supporting it, it could be billed separately as that significant additional level of effort. And one of the examples Mary Sue is going to be going through today is going to show you just that. Where there's two, it's going to show you the documentation so you can see what that looks like. For the second example, for separately identifiable, you have a patient that's come in for an annual wellness visit, and during that visit, they indicate that they are experiencing some new knee pain. So the doctor then goes on and evaluates the knee pain to determine the cause. And this can include ordering more tests. It can include analyzing that data. And the documentation clearly identifies what portions of the visit were for the AWB and what portions of the visit were for the knee pain. That evaluation of that knee pain is not going to be part of that AWV. So provided that the documentation supports both, that workup for the knee pain could potentially be billed as a separate E&M service. So now I want to talk about using Modifier 25. So Medicare or CMS requires that Modifier 25 should only be used on claims for E&M services, and we did get quite a few questions on that. You're only using Modifier 25 when the services are provided by the same physician or MPP or other qualified non-physician practitioner to the same patient on the same day as another procedure or other service. One of the things that we see is Modifier 25 will come in on everything, and that's not appropriate. We'll talk about that. Because the procedures, again, as we stated, already account for a certain level of that E&M service, we just need to make sure that the documentation is supporting how the services that separate E&M is not typical, or that it's above and beyond, and that a significant amount of additional work or cognitive load involved in that MDM. Modifier 25 does allow for that additional payment. I did indicate that this is a payment modifier. So making sure that that documentation supports that avoids any type of adjustments that need to be made if that claim is being reviewed. So as I said, the modifier 25 is only going to be used on the E&M services. If you have a procedure and an E&M, we did receive questions about this. You're not putting it on the procedure, you're putting it on the E&M code. You're putting it on the code that is that additional separately payable code. So keep that in mind. We did also receive some pre-submitted questions that were asking about diagnosis and what diagnosis needs to be on the claim, or what diagnosis supports a separate E&M code to be billed in that use of that modifier 25. So diagnosis really is not the deciding factor for the use of modifier 25. Again, it depends on what's done for the patient and what that documentation supports. So while that patient's symptom or condition may prompt the E&M service, so I'll go back to that AWV with the knee pain, it's not a requirement and it's not the sole determinant of whether or not that modifier 25 is appropriate. It again truly comes down to that documentation and if the documentation supports both services. So I have a couple of other pre-submitted questions I want to call out here. The first one was asking if the practitioner has to determine a diagnosis to consider multiple treatment options, might modifier 25 be justified? And as I was just saying, it could be if that documentation supports that it was significant and separately identifiable work from what's typical for the encounter that they came into. So we also get the questions about that were very specific to, I have this procedure and an E&M. Is it billable? In fact, that was the bulk of the questions that we did receive today. The answer to all of that is going to be the same. It is going to be what the documentation supports, pulling out the pieces that support the procedure or other service, and is there enough left to bill for a separate E&M code? So I want to talk about that documentation a little bit. Mary Sue's going to go through some, but I want to give you some things to consider when you're looking at that documentation. So things that you want to look for. It should be clearly stated why the additional E&M service was needed. Again, elements of E&M are included in these other services, so you need to figure out why a separate E&M is supported by that documentation. Why was it medically necessary? And then what prompted it? Is that clear in the documentation? That's going to help. Why did they bill? Why are you billing that extra E&M? How is it significant? How is it separately identifiable? It has to be clear in the documentation that this MDM, this work was for the procedure and this work was above and beyond that. So you need to show us that. How is it unusual? The documentation is your proof of thought, and it needs to tell your story. You did the work. Medicare wants to reimburse you for the services, and we're not asking you to write a novel, but you do need to provide the elements that show why the services are supported. That has to be evident in that documentation. We do suggest pulling, like I said, pulling out the integral parts of the procedure or other service and seeing what's left, and you'll hear that from me a lot. But it really is going to apply the same way for any type of specific service. As I said, we did get pre-submitted questions that included various procedures, various specialties, and ultimately the answer is going to come back being the same. Does that documentation support? So I want to go through using modifier 25 inappropriately. So I mentioned this one already, but applying it to every service just to see if it sticks. I'm not saying anyone's intentionally doing it, but that is kind of what that appears to be. But you don't apply it to every service. You don't apply it to every E&M service. There needs to be that other service or that other procedure. If you're just billing the E&M service that day, don't apply a modifier 25. It's not needed. It's not going to cause the claim deny, but why was it there? If the documentation doesn't support, again, pulling out the base procedure and then seeing what's left. If what's left doesn't support it, you're not going to be billing for that additional E&M with that modifier 25. It should not be used by a physician other than the provider that's providing the other service. So if they're seeing different providers, if they're in different groups, again, this is same patient, same provider, same day is when you're going to apply that modifier 25. Also, we received a question asking about new patient visits and procedure code on the same day. This can often happen when there's a referral to a specialist. So don't automatically append that 25 to those E&M codes. Again, there's that different provider piece. You want to make sure that you're looking at that. Don't apply it to services that you know are automatically excluded. It's not going to cause those to pay. And then we also received multiple questions about the use of modifier 25 with G2211. And that is that add-on code when the provider is the patient's focal point of care. So typically modifier 25 is not payable on the same date of service or is not applicable with that. However, as of January 1st of 2025, CMS put in the final rule that G2211 can be used with certain preventive services, and it's a small group. It's going to be your Part B preventive services, it's going to be immunizations, and it's going to be that annual wellness visit. And I am asking Mary Sue, and it looks like she did, thank you, to add a link to the chat for information on that. Also, I do want to shout out to one of our colleagues, Ashley. She's going to be doing a webinar focused on G2211 later on or early in 2026. So that's something to look for if you're interested in that. So suggestions to help this go more smoothly for you. Perform a self-audit and ask yourself the questions we've talked about here today, making sure that documentation supports it. Why was it medically necessary? How is it significant? How is it distinct and separately identifiable? Identify any incorrect use. It could be that you have edits or audits or some types of triggers in your system that are automatically applying it. Look at those. Do they make sense? You may need to turn some of those off or adjust those. And then if you're finding that you've gotten payment for services that are not appropriate, that is something that you may want to consider making that refund. If it's something that we review it, we're going to take that money back. You're going to want to get ahead of that. So before I hand things off to Mary Sue, I do want to talk just a little bit about global surgery. It's not the focus for today, but it is definitely going to have some impact on what Mary Sue is going into because we're talking about those procedures. So again, CMS allows for reimbursement for an E&M on the same day as a global surgery on a procedure with a global surgery period. However, the same things are going to apply. The same key elements are going to apply. It has to be significant. We need to know why it's separately identifiable. It has to go above and beyond normal pre or post-operative care, and it has to be performed on the same day as a procedure. If it is a distinct service, that is when modifier 59 is going to come in, and I just want to call that out. Modifier 59 is different than 25. Modifier 25 is defined as a distinct procedural service that identifies a procedure or a service that's not normally reported together, but appropriately billable under the circumstances. And again, that documentation has to support. We're not going in depth into this today, but because it is going to impact some of the examples Mary Sue shows you, one of the examples does have that. I wanted to make sure you had that information available to you. So with that, I am going to hand things off to Mary Sue for documentation examples. Mary Sue?
Thanks, Leanne. And give me just a second to share my screen. and get things rolling on my end. Again, just like with Leanne, you may see a few boxes moving around, and that is perfectly normal as I ready my screen. Just pulling a few more things out. Okay, one thing you may or may not notice, depending on how you are connected to this webinar, if you connected via phone or if you are connected via audio through your computer. The audio levels of Leanne and I may be different. So you may have had to adjust your audio down a little bit for Leanne's. Hers was coming through her computer, where mine is coming through a phone, so you may need to turn your audio back up. So I just wanted to point that out to people that that's perfectly normal, and it really just depends on how you are connected to your audio. Thank you again, Leanne, for turning this over to me. As Leanne said, my name is Mary Sue Gardner. I am actually a registered nurse on the Provider Outreach and Education Department. Leanne and I tried to do this webinar earlier this year, but technology was not our friend, and we ran into a bunch of technological issues. We had some audio stuff, so we needed to put that to the side and just redo this in full. So that's where we are today. We're going to shift gears a little bit from what Leanne was saying, and we're going to go into some documentation. Before we do that, let's talk about some general principles of documentation that must be present in all documentation. So these are just wherever you practice. First, documentation has to be complete and legible. All documentation must be dated and signed, and signature must be legible by the person that's documenting and include credentialing. So all documentation must also support the diagnoses and treatment codes that you're going to bill. Now, when it comes to E&M services, some of the specific requirements for evaluation and management services that need to be included in documentation include a complete legible record showing the encounter's reason. Why is that patient there? Relevant history, exam, any kind of data that goes into your encounter for that day. Any assessments, diagnoses that are made, and the patient's plan of care. Everything in your documentation should also be supporting the billed services at the level that they're billed. And sometimes, you know, as you know, with E&M codes, it pertains a lot to the medical decision making. So we have to have evidence in your documentation of that physician or non-physician practitioner's medical decision making. Time is a component with a lot of E&M codes. So we need to see total time of treatment or services direct one-to-one with that patient, not when they came to the office and when they left, because we all know we've gone to the office for whatever, and we've sat there for half hour, sometimes even more. Anyways, any kind of data that helps with the complexity of your service. Were there tests? Were there any prior records that needed to be taken into account? Any risk of complications, those are key elements for your medical decision making. Let's see, providers must also document accurately at the time of service. So we're going to be looking for that information that supports the medical necessity. Often that reflects your CPT guidelines too. And you have to follow what those CPT guidelines are to make sure you're billing at the appropriate level. So your medical decision making, your time, you know, not detailing history and physical elements, those all go into what level of service you could bill in your E&M as well. When it comes to plan of care, some important things to remember are not only what your plan is, but how the things that you are doing for your patient relate to the plan of care. So the plan of care should detail the patient's treatment, the next steps, the ordered tests, the referrals, things like supporting the assessments, reflecting that complexity of that encounter for your accurate coding. So whether it's based on medical decision-making or total time spent, is regardless, your documentation has to support that. Some of the key elements include clearly stating diagnosis, outlining any of those tests or treatments, specifically follow-up, and those follow-up plans, and adding rationale for all decisions. And that's all really to justify the billed service levels. So let's say, for instance, to kind of wrap this up, you provide some lab work. Then you must document the results of that lab work and what you plan to do with those results. If the results are within normal limit and there's no change to the plan, then you document that. If the results elicit the need for a phone call to the patient and a change in medication, then you document that as well. As we move on, accordingly, I've already discussed this, but we need, again, that rationale for ordering those diagnostic tests or other services. So basically supporting the reason why you ordered what you are ordering. Let's see. We're going to look for appropriate health risk factors to support your services as well. Many times with E&M, there's a component of time. So again, time must be documented. Even if time isn't a driving factor for the E&M that you are going to be reporting, it's only going to behoove you to make sure that you are documenting that time component. Because if it has to be recoded for some reason, then we're going to be able to support with the documentation of time. Progress notes. Progress notes are so important. They're like the key to support what you're doing, why you're doing. So remember, sometimes you are getting subjective information from your patient. I have pain. I'm having issues bending. Then you need to quantify this information with objective and measurable information. Can you rate your pain on a scale of 1 to 10, with 10 being the worst? Oh, your pain is a 5 out of 10. Now you have documented objective and measurable information about that patient's pain. Again, it is only going to behoove you and your staff to always document in objective and measurable terms. And anytime you can give us a length, a weight, a measurement, a percentage, whatever the case may be, an amount, it's going to benefit you. And finally, attestation statements, if they are applicable in the case that you are missing a signature. So before we jump in, let's talk about some common documentation issues. If your documentation doesn't support the level of service it is billed at, it will either be recoded or it could just flat out be denied. A lot of times we see this with E&M codes and E&M codes that have a time component and the documentation doesn't support, that time was met. Other things are signatures and signature attestations when signatures are required. Let's face it, we need to know who completed the documentation. So the signature must be there. Signatures also have to include credentials because we have to verify that the right person completed the task or completed the work. So if there is a procedure that requires a physician, we would expect the documentation to have that physician signature and credentials. And remember, if it is illegible, if you're still keeping handwritten documentation, then we need to see that legible signature as well. Minutes of service we've talked about a lot. That's because it is a component that is very often missing in the documentation. So this is time, again, that is actually spent with the patient, not time reading the chart or time that the patient entered and exited the exam or treatment room. And then we get down to significant and separately identifiable. And Leanne and I are going to just drill this into your brains as we go through this. Remember, if you can take all the documentation away that supports the Part B service that was provided, and what is left supports that a separate E&M service is identified, then you probably have enough to build both using the modifier. So when we get into the documentation examples, I'll actually show you what that might look like. Now, I'm going to be pulling in some actual documentation examples on the screen, but I want to give you some slide information, a little bit about this claim before we jump into it. So the first claim is for an annual wellness visit. And this is some of the background information on it. So we have date of service as 1/13 of 2025, place of service was physician office. Here's CPT and HCPCS codes that were billed. So we have the E&M with the modifier 25, along with the annual wellness visit and another modifier 59 on the G0444, so the annual depression screening, and then some collection of blood. So let's pull in the documentation. I'm pulling this up, and I'm going to scroll back all the way back up to the top of this. And this first claim, whoops, make sure that is full screen. Okay. Is the annual wellness visit. So some of the basic information on this claim, again, was on that slide for you. We have a claim here that came in for an annual wellness visit. The things that we found in this claim, again, that date of service was 1/13, and it was performed in place of service 11. And then, of course, we have that venipuncture and all of that information. So in this documentation for this claim, I want you to keep this in mind. This is a claim that was submitted for review of annual wellness visits. So the 99214, it was not under review for bulk services, but for education purposes, we want to show everyone how we need to see separate and distinct services for the two codes to be reported together. Remember, you cannot double dip services. What I mean by that is that all the documentation to support the annual wellness visit can only be used towards the annual wellness visit. You cannot also use that information towards billing the office visit as well. So when we get into all the specific examples, whether they were submitted prior or whether they were submitted in the chat today, I'm going to have you take away some of the things that I'm going to do in these examples and help you determine if you can build those together or not. All right, so let's see, let's get into this. This person came in for an annual wellness visit and BKD appointment, which I'm not really sure what this acronym stands for, but we're thinking they had some sort of complaint for the day by that. We don't know what that acronym actually stands for. Knowing that we looked at the claim for annual wellness visit, let's look at this review and try to find the documentation. So if you have gone to any of our preventive services webinars, or you look at the preventive service information on CMS's website, and look at the annual wellness visit information, there's things in there that we actually review for. And I am going to place a link into the chat, and I'm going to quick pull it up on the screen. And whoops. That did not go to the right thing. We'll just put it in there. I'm just going to cms.gov. I used that link, and I am going to show the components of the annual wellness visit. And if you go to this link yourself and you go through all of these elements, that is exactly everything that we are looking for in an annual wellness visit review. So as I go back to the documentation, in this documentation, I'm going to look for all the information related to the annual wellness visit. And I'm going to be verifying to make sure that it was all there. And they went through and they have their past medical history, and they have their surgical history, and their depression screening that they did with the PHQ-2 or PHQ-9. We have family history, alcohol, social history, vital signs. We have some assessments, encounter for general medical examination. They're just telling us a little bit about why that person's here. And I know I'm scrolling fast, but I've highlighted some of the stuff that relates, or most of the stuff that relates to the annual wellness visit. And all of this information, and we scroll down here, and then we have some information about the preventive service screening, etc. Now, in this particular case, they were billing the annual wellness visit along with an additional E&M code. So let's take out all the information that related to the annual wellness visit and see what we have left. Let me pull this back up. So what's left? I have a reason for the appointment, the health risk assessment, that all pertains to the annual wellness visit, all of the surgical information, family history, social history. We have some vital signs. They're not part of the annual wellness visit, not entirely. Some general examination. And then the rest of it is just what they plan on billing. And then as we scroll down, again, procedure codes that they were going to put on the claim, etc. So there's not enough information here to support that E&M code. You can do the exact same thing in your office. You can take a claim and you can look at the documentation and take everything out that relates to that procedure, that relates to the injection, the EKG, the whatever it may be, and do we have enough left to bill the annual wellness visit? In this case, we didn't. There just wasn't enough information left. All right, so just real quick, and I know I'm going through these kind of quick, but I want to show you these things. So these are the findings in this claim, and we already talked about them, but I just wanted you to know I have that information built in here as well. We had all the components that were supported for the annual wellness visit. The depression screening, that is part of the annual wellness visit, so that code cannot come out separately too. Removing all the information related to that annual wellness visit and depression screening did not leave enough information to support a 30-minute moderate level office visit in this case. So moving on, I'm going to jump back to the documentation again, and I'm going to go to our next claim, which is an I claim. And Leanne talked about this a little bit. So in this one, and again, in your notes here, and you're going to have the information about the claim and you're going to have the findings, but I'm just going to show you that in the documentation. So we have a date of service of 11/1 of 2024 with a place of service of 11. So we had the J2778 with the modifier JZ, the 67028 with the modifier of RT or right, the 99214 with the modifier 25 on it, and the 92134. So basically, this person came in for an eye injection for their macular degeneration, and that was the reasoning for the visit on this encounter. So that information is all up here. The reason they were established visit, they have neovascular AMD, which is wet AMD or age-related macular degeneration, and that causes some central vision loss. So they have active CNV of the right eye, and CNV is actually a condition where like new abnormal blood vessels are growing in the eye. So they've identified that here. And they have some dry AMD to the left side. So as noted, there's also some choroidal nevus. I'm going to screw up the I words, sorry for my mispronunciations, but it is what it is. Anyway, so that's a benign growth of the pigmented cells of the eyes. All right, so let's talk about a few things that are considered standard. The patient presented for their eye injection. Some standard testing before an intravitreal injection includes a brief exam. It also includes a vision check and some history updates. There's some baseline optical coherence tomography or OCT testing to address the retina's layers and check for fluid. And this really helps confirm a condition is active and determine the readiness for that injection. So we will look not only for the documentation to support the injection, but is there enough that's significant and, separately identifiable to support the E&M as well. So up here under the chief complaints, again, follow up for the neovascular AMD, and they've also had some cataracts here and a little bit of history, but right here under the extended HPI, patient reports something has changed, but not sure which eye. They deny like flashes, floaters, the left eye is greater than the right, an itchiness, etc. They have a history of posterior vitreous attachment, or PVD, which is a medical emergency if that happens to occur. So when something is reported and a patient is not sure what's going on with their vision, and especially when they have a history of detachment, that warrants additional testing. So as you look through this claim, you can see all of the testing that was done. They did some Snellen chart testing. They took some pressures. They did OCT testing, etc. They have some findings down here. They give an impression, a plan of care, etc. Now, let's switch gears with this claim. And I'm trying to be, considerate of everyone's time as well. They ended up proceeding with the injection. They give us the information on the injection as well. When we take out the information that is needed for the right eye and the injection of the right eye and see what is left, do we have enough to bill the E&M service? In this case, the answer is yes. We have a report, something is different, we don't know what that is. To make things easier in this case, I just took out everything regarding the right eye. But with the patient not knowing if it's right or left or what's different and what's not normal, they just know something's not right. To make it easier, I said, okay, let's just eliminate the right eye because they weren't there for that right eye. And all of the testing and all of the findings regarding the left eye, do we have enough to bill the E&M service in this case? And the answer to that was yes. There was something that was significant. There was something that was separately identifiable that made the need for this additional testing to happen and made the testing support the billing of that E&M with that modifier. So this is a good example of how you can see the information, supporting the other service and containing that, information that was necessary. And then finally, our last documentation was on some skin lesions. And again, this came in for a skin lesion review, but it happened to have an E&M service on the bill as well, with a modifier 25, so the 99213. They also billed the 17004, which is destruction of those skin lesions, and the 17110 with a modifier 59, which is up to 15, destruction of skin lesions up to 15 lesions. And of course, the modifiers 25 and 59 were on this as well. So as we look at this, we have a patient that is there for a skin check. He was established patient, there for a skin check, also had, reports some bumps that he hits with his comb, rough spots on his face, felt that those numbers were increasing. So the examinations were performed and included his head, his face, his lips, his chest, his neck, right upper extremities, left upper extremities, abdomen, back, blah, blah, blah. So we go through, we have a little bit of information about, we've got some family history, we've got some past medical history, and then what we did with all those skin lesions and the treatment to those skin lesions. And there again, I'm trying to be respectful of your time, and I know we're getting close, but for these purposes, everything that was removed for the visit for the skin lesions and removal of those lesions was taken out of this documentation. And do we have enough for a separate E&M code to be billed? And the answer to that was no. Those lesions that were separately identified when that patient first presented or that are new to the patient, those were included in the checks and the treatment that the physician did. The patient just noted them as new to them, but they were included in and treated as a part of those treatments that the patient actually received. All right. And I know that was fast, but again, trying to be respectful of everyone's time. So I gave you the information regarding the skin lesion claim in here as well, and the findings. And again, they went in for that skin check and noted some rough spots on their face, and the check included all of those areas being looked at, being assessed, being treated. We have impression and plan for all of that. There was just not enough documentation to support that low-level office visit. All right. So again, the point of this review or these reviews was really to show you how services cannot be double-dipped. You cannot use the same information to support two different codes. If you're going to report an E&M with like the skin lesion codes, then it's got to be separate and, you know, identifiable. The services would also need to support the time, the medical decision-making in the skin lesion case. What additional complexities or problems were addressed? How many self-limiting or minor problems were there? Is there chronic illness, undiagnosed new problems, side effects of treatment, anything life-threatening that's going on? So in these cases, we cannot even talk about the complexity because everything in this last case pertained to the skin lesions. So we only have what information, you know, again, was left over to try to make that determination for the evaluation and management. All right, so on your screen, and I'm not going to go into these, but there's a plethora of resources. And they're good resources. And I encourage you to go in and look at all of these resources. And we actually have 2 pages of resources for you. So let's recap really quick what we went over. And I want to hit one more pre-submitted kind of roundup of Q&A before we move on. And I thank those of you who are able to give us a few extra minutes of your time. So today, our objective was for you to learn about when it's appropriate to report an E&M service with another Part B service. We met this objective by discussing that appropriate billing and appropriate use of modifier 25, as well as when it's inappropriate. We also use that live documentation and those examples to support how a claim is reviewed to really support being able to report both of those codes on a claim together. Now, again, I'm realizing we're at time. I'm going to thank everyone that is able to give us a few extra minutes. And if you have to drop off, just know that we will have the recording of this up on our YouTube page probably by tomorrow. Leanne and I are pretty quick. But many of the pre-submitted questions that we received went something like this. Can we bill, or how can we bill, insert Part B service and E&M insert code with modifier 25? And that comprised the majority of our questions. And the answer to that is maybe. It depends on if it is significant and separately identifiable service. If the E&M involves a new problem, a significant exacerbation, or it requires distinct work, like a complex or whatever history, exam, medical decision-making, anything that's beyond that usual Part B service assessment or Part B service itself, it could possibly be billed. It would not be significant and separately identifiable if the patient comes in for, you know, if they come specifically for a planned Part B service for an ongoing issue. If the E&M elements are considered integral to that procedure. So again, ask yourself, are the services integral to the Part B service or procedure? Are the x-rays integral to having that injection? Is the EKG an integral part of the examination that needs to be done by the cardiologist? Is the eye examination an integral part to the intravitreous injection that's being done? If they are, then they cannot be counted towards an E&M. All right. With that in mind, I know we're running a few minutes over, and Leanne and I are going to take a look at all the questions in the chat, and if there was anything that didn't get answered by what we were specifically saying, you know, and If a question came in and it was insert Part B service with insert E&M code, then we feel that we've answered that. So we may not specifically respond to you on that specific questions. But I know there was a few billing questions that were a little bit separate and a few clinical questions that Leanne and I will take back. We will then formulate all the questions and send them to everyone if they're pertinent to everyone. So a few things. We value your opinion. And we want to hear from you on how we did on this event. So the survey for this event only takes a few minutes to complete, and that's why we want to give you the opportunity to use the link and take it now, or when the webinar closes out, you'll be automatically directed to the survey. Losing my words. We really value your opinion, and we want to know. We want to know the good, the bad, the ugly. But mostly we want to know, what else can we bring you in the future? So it's your opportunity to tell us what additional education that you need. So please, if you take it for no other reason, take it to tell us what else that you want in the future. All right, remember to read the notes section of the slide deck because it has some information. If you have questions and you want to send those questions to us in the notes section of the slide deck, it tells you how to do that. I just want to give you a reminder, please don't send us any PHI or PII. We can't open it, and we won't open it, and it'll be deleted, you know, because we don't want you or us to get in trouble for receiving any kind of protected health information. So those questions need to be directed towards customer service. Leanne and I do not have access to the claims processing system, so we can't look up claims for you. So if it's claims related, then please direct those to customer service. Otherwise, you have a week to send those questions to us. So again, that brings us a little over time. I want to thank you for spending your additional time with us. Leanne and I, again, are going to take those additional questions back and provide some answers to those. But on behalf of Leanne and myself, as well as our medical review department and the rest of our PO department, we want to thank you for your participation in today's event. So this is going to conclude our webinar, and we wish you all a very happy holiday. And you may now disconnect.